I've attempted to take my life on 2 occasions, so I speak from a place of lived experience, and without a doubt I can say that leadership is integral into implementing change in the space and changing the way that we see suicidality in the healthcare system.
The first thing healthcare executives have got to do is focus on understanding what is the context in which this innovation is going to operate, of understanding the system, the ecosystem in which this particular innovation is going to sit. So with zero suicide, what that means is understanding what are the demographics of the population, what are the healthcare services that sit outside of a hospital, what are those things that are going to support people, but also prevent crisis presentations, so that we're doing all we can to ensure that those people that need crisis support get that service. The second thing I think that's really fundamental is engage people with lived experience from that community. It's those people who have encountered the healthcare services in their area, and they can actually provide a real insight into what worked, what didn't work so well, what did they really need, what mattered to them in terms of dealing with the suicidal crisis and actually recovering from that point. It's fundamental to improving service, and I think it drives the changes in behaviour, the changes in practice that are needed amongst the healthcare professionals if they hear it firsthand from people who have experienced services.
I think it's really important to have that mix of professional advice and lived experience when we're talking about implementing change in this space. I think either one on its own in isolation doesn't have enough substance behind it.
One of the really practical tools that organisations can use for cultivating a just approach is by including all of those people who may have been impacted in an adverse event. So we've had root cause analysis in hospitals for quite some time, but often they're not done in a way which enables people to really drop the defensiveness, be open to what happened and how they could have done it better, include very respectfully the experience of the consumer, their carer, their family in that process, and through that, learn what is it that they could do better and apply that. I think this is a really practical way that we can demonstrate, a non-judgmental, inclusive, respectful way of responding to people with suicidal crisis and needs. I think it's really important that staff look to a number of ways that they can engage their healthcare services leadership in Zero Suicide Initiative. So one of the ways of doing that is to bring the data to life, show the executives what the data is really showing in terms of efficiency and effectiveness. We know that people presenting with mental health related problems and suicide ideation are climbing very significantly in Australia. And we also know that those people wait on average 3 times longer for a hospital bed than other patients that are presenting to our EDs. But also bring the lived experience that people are experiencing in the healthcare setting to life. And the best way to do that, of course, is have the voice of the consumer, the person experiencing the care, actually present that to the executive. If it can't be done directly, then capturing it digitally in various electronic forms is one way of doing it.
The lived experience piece really allows an audience, whoever that may be, whether it's a community group or a group of doctors, group of clinicians, nurses, to really understand how mental health struggles and crisis point and suicidality manifests within someone. The only way that can actually be described is by someone who's lived it.
They can show the evidence from elsewhere where zero suicide has been applied and the results that have been achieved, and demonstrate it has a good evidence base. So bringing partners to the table can often get executive involved in terms of determining what's the best way that our service can interact with these other players. So like our police forces, our ambulance, even some of our transport services, they can actually bring data to us that shows how suicide is impacting on what they're responsible for doing in the community. Well, Zero Suicide and the model really focuses on preventing suicides in healthcare settings. It's designed to ensure that once a person makes contact with the service, that they're provided with the best possible care and continuity of care to ensure that that suicidal crisis is diminished. So Zero Suicide is really focusing on those things that are within, if you like, the remit of the healthcare service directly. I think healthcare executives always understand that when they're trying to undertake a transformative change, and a change that affects many of the units within a healthcare setting, that's not going to be a sprint. This is a marathon. What we're doing is trying to change culture, we're trying to change practices, we're trying to change outcomes. Changing those practices across those different settings is not going to happen overnight, but it is going to take sustained and really assertive responses. It's hard work, but it's incredibly rewarding. And by doing this, we provide justice for people who have got mental health, suicidal behaviour.
It's a really volatile time, I think, that initial period that someone reaches care after trying to take their life. And I'm just so lucky that the care that I got was so gentle. A lot of people have had not great experiences like I've had, and I was just extremely lucky that the people that were caring for me really connected with me, and I connected with them, and I trusted them.